So, hello everyone, my name is Samantha. I am the director of the Acute Leukemia Advocates Network. Today we are going to speak about acute myeloid leukemia and the highlights from the EHA Congress that happened in June. And today Professor Röllig has kindly accepted to take us through 7 studies which are important for patients.
Yeah, thanks very much, Samantha, and hello from my side as well. This is a short disclaimer, and these are my disclosures. And after those disclosures, I will jump right into the first study. In general, the study outlines will look like this. So this is the title slide. And within the next couple of minutes, I'll very briefly present the raw data from the abstracts that we've seen at the EHA meeting. And you can stop whenever you like in order to kind of read all the details, if that's not enough time while I'm going through the slides, which means we will not read out all the details on the slides for you, but you can stop whenever you like and go into the details. And our recording here is meant to be a brief overview. After each of those abstracts that I'll briefly present, Samantha and I will discuss and explain from our point of view what this could mean for patients, what these results and data could mean for patients. And I start with a study that addresses one of the so-called menin inhibitors. That's a new compound class for the treatment of acute myeloid leukemia that works in particular in patients who have a so-called NPM1 mutation and patients who have a KMT2A rearrangement. These are genetic changes in AML that occur in about 30% of patients altogether, 35% of patients, so around 1/3. And those patients can be treated not only with intensive chemotherapy in general, but also with these called menin inhibitors. There are several menin inhibitors in clinical development, and the one we are looking here in this abstract is called ziftomenib. And this ziftomenib was added to standard chemotherapy that patients received for the treatment of their leukemia that was just newly diagnosed. So patients were included in the study. They received so-called induction chemotherapy and consolidation chemotherapy, and then a so-called maintenance phase. For those 2 chemotherapies, ziftomenib, that is a tablet, was added on top of chemotherapy. And then after chemotherapy was finished, the ziftomenib tablets were continued. These are the results. You can see on this column the results for the NPM1 mutated patients, and here for the KMT2A rearranged patients. And we first look here. This is the overall response rate, so all patients who have responded to the therapy. And you can see this is almost everyone. So almost every patient actually responded well to this chemotherapy plus ziftomenib. When we look at overall survival, you can see here over time, 100% of patients we start here at time 0, and then we see after those many months how many patients are still alive. And you can see that after 24 months, almost all patients are still alive, which means they have a good outcome. This is the results for patients with NPM1 mutation. And for patients with KMT2A rearrangements, this is a genetic change, or that's a genetic modification of AML that has a very bad prognosis in general, which means many patients do not respond to treatment and die quickly after initial diagnosis. But you can see the results are not as good as with NPM1, but still a majority of patients is still alive after 2 years, which is a very good outcome if we compare this with results from studies in the past. If we look at tolerability, that means the side effects that occur for this combination, we see that they are very similar to side effects that we see with intensive chemotherapy. And in general, it's always quite difficult to distinguish the side effects from chemotherapy from the side effects of chemotherapy plus a certain additional drug such as ziftomenib. But in general, they look familiar to us. So this is the conclusion or the summary of what we have seen. And in general, from my point of view, that means that ziftomenib works well with intensive chemotherapy. Ziftomenib is only one of a couple of so-called menin inhibitors that are in clinical development currently. And if these drugs prove to be efficacious and well tolerated in many clinical studies that are currently ongoing, they might be approved and they may be available for patients in the future to increase or improve the results of their treatment. This is my take on the first abstract. Samantha, what do you think?
I think, so to me, it's one of the most striking results we have in AML for quite a while. So definitely it needs confirmation with a larger phase 3 trial, I would say. But definitely it's quite good news for patients who have those mutations.
Exactly. Maybe some background information. This ziftomenib is already approved in the United States for the treatment of patients who have a relapse of their disease and who have an NPM1 mutation. And there is another NPM1 another menin inhibitor that is called revumenib that is approved in the United States for the treatment of relapsed acute leukemia with and KMT2A rearrangement. It still means that outside the US, patients cannot generally get those drugs. However, in some instances, it is possible to apply for the reimbursement of those drugs by the health insurance company of patients. So some of those, including ziftomenib, are in clinical use as single agents already in the relapse refractory setting, but we may get them as a first-line treatment in the future. Okay, and with that, I think I'll come to the next presentation, and that was an abstract for patients with a FLT3 mutation. FLT3 mutation is another genetic change that occurs quite frequently in AML. Around 1/4 of newly diagnosed patients, so 20–25% of newly diagnosed patients have a FLT3 mutation. And in general, we have drugs that may be added to intensive chemotherapy that may improve the outcome of this intensive chemotherapy. And these drugs are called FLT3 or FLT3 inhibitors. And in general, we have for the so-called FLT3-ITD mutation, we have 2 drugs that are approved that can be used as addition to intensive chemotherapy. One is called midostaurin and the other one is quizartinib. However, we do not have a study that compares the two. So currently it is unclear if a patient has newly diagnosed AML with FLT3-ITD, is it better to use midostaurin or is it better to use quizartinib? And the results that I'll present you in the next couple of seconds is from a retrospective comparison. That means it's not a study in which patients are randomized. One half receives midostaurin, the other half receives quizartinib, and then the outcomes are compared. But the researchers took a group of patients that were treated with quizartinib in the past. They gathered those data, and they took a group of patients who were treated with midostaurin in the past, and they compared the outcomes. So the level of evidence, the certainty we have from those data is not so high as in a randomized prospective study, but it can give us some hint on which drug should be possibly better. So patients were gathered who had FLT3-ITD, newly diagnosed. 127 patients were treated with midostaurin, 88 patients were treated with quizartinib, and then the researchers looked at the outcomes. The outcomes are here. This is 1 year overall survival. I will show this to you also as a graphic representation in a second. You see, with midostaurin, 78 patients are alive after 1 year. With quizartinib, 93 patients are alive after 1 year, which is significantly more. And if we look at the patients who responded to therapy, that is a so-called composite CR rate, also more patients responded to quizartinib than to midostaurin. The toxicity, the complications that occurred were not significantly different, with the exception of the so-called admission to the intensive care unit that was slightly more frequent in midostaurin group. This is the graphic representation of the results from overall survival that I mentioned already. The red curve is quizartinib and the blue curve is midostaurin, and you can see significantly more patients live after a certain amount of time with quizartinib compared to midostaurin. And as I mentioned, the outcomes for the side effects or the adverse events are similar. So the two drugs are equally tolerable or cause equally adverse events at a similar frequency, which means so there is no big difference in tolerability. So in general, we cannot be 100% sure about the better efficacy of quizartinib versus midostaurin because these are retrospective data, but these data give us some information that quizartinib is at least not worse, but it could be more efficacious than midostaurin actually. That's my take. What do you think, Samantha?
Yeah, I agree. To me, it's a study which it's one of the first in showing real-world evidence, and the data seems to go towards quizartinib with a better survival, remission, but also tolerability during induction. So that might be something to consider for patients. Then maybe a question to you, since both drugs are approved, what can patient really choose between the drug, or is it this physician choice, or how do you normally make the choice between the two drugs?
Yes, so normally it is the case that a physician suggests a treatment to patients, and if patients live in a country in which both drugs, quizartinib and midostaurin, are reimbursed, then the physician would base their suggestion on the data that we have. And we don't have comparable data. There is, if we compare the outcomes of the two studies that led to the approval of the two drugs, it looks also as if quizartinib is slightly better, in particular in younger patients. But these data that we've just seen confirm this, that it is better, and it may even also be better, quizartinib, better than midostaurin in elderly patients. So this data for me would mean that I would rather use quizartinib instead of midostaurin for patients who have FLT3-ITD. And from the patient perspective, it is advisable if a patient is diagnosed with AML and has FLT3-ITD to ask the doctor why he chose midostaurin or quizartinib, or if the suggestion is midostaurin, why midostaurin is preferred, what are the reasons on the doctor's side, and why quizartinib is not preferred, because the data tend to rather support a use of quizartinib in this constellation. Okay, and it's good that we've talked about this in detail because there is another study comparing another FLT3 inhibitor, but the difference is that this study now is not a retrospective data comparison, a real-world data study, but a prospective randomized study, which means a study in which patients are by chance distributed. One half receives one FLT3 inhibitor, the other half receives the other FLT3 inhibitor. And as opposed to the study that we've just seen, here midostaurin is compared not with quizartinib, but with gilteritinib. Gilteritinib, such as quizartinib, is also a newer FLT3 inhibitor, whereas midostaurin is an old FLT3 inhibitor. So patients who had a FLT3 mutation and were fit for intensive chemotherapy and had no previous treatment were randomized, which means one half of the it's a 1-to-1 randomization. So you see many patients were randomized. Almost 400 patients received gilteritinib on top of chemotherapy. The other half, the other almost 400 patients received midostaurin in combination with chemotherapy and also as maintenance once chemotherapy was finished. And then again, researchers looked at the endpoints, which means overall survival, but also response rate and also so-called relapse-free survival. And this is, in a nutshell, the results for the survival and for the response. But I will show this to you in a graphical representation that is slightly easier to understand. So this curve shows you the so-called relapse-free survival, which means of all patients who have achieved a remission, who responded to this treatment, they start here. And then you see in the red curve, the patients receiving gilteritinib, fewer patients have a relapse or died who received gilteritinib treatment as opposed to midostaurin. And this difference is statistically significant, which means if we look at relapse-free survival, which was not the primary endpoint of the study, we see gilteritinib is better. However, the primary endpoint of the study was overall survival. And if we look at overall survival, you can clearly see there is no difference between those two groups of patients, which means in general, if we look at the overall survival of all the patients with midostaurin lived as long as patients with gilteritinib. And the reason for that is that gilteritinib is approved in the relapse refractory setting, so outside a clinical trial, if patients relapsed after midostaurin treatment, most patients received gilteritinib as a salvage treatment, and then a majority of them went to allogeneic stem cell transplantation, which means all the patients with midostaurin who additionally relapsed after the treatment could successfully be salvaged or saved with gilteritinib treatment afterwards. And that effect actually led to the no difference in overall survival that we see here, which means that if we look at the general life expectancy of patients, it is not better if they receive gilteritinib in the first line as opposed to if they receive midostaurin in the first line followed by gilteritinib in case of relapse. And that also means that based on these data, we will not get an approval for gilteritinib in first line treatment. Samantha, what's your take on that? What did you think when you saw the data?
So what I thought was that the current standard of care, which is midostaurin plus chemotherapy, remains the standard of care for those patients. That in any case, the trial also confirms that the survival with midostaurin is actually quite good. And also that the order of the FLT3 inhibitors can actually matter, because if you start with midostaurin but then you get relapse, then you can go through salvage therapy using gilteritinib. So it's actually quite a good option for patients.
That's absolutely true. And for those of you who are now totally confused when it comes to quizartinib, midostaurin, and gilteritinib, we are also confused because we do not have comparative data that compare quizartinib, for instance, with gilteritinib, or we cannot say, is it better to receive midostaurin or quizartinib in the first line if we still have this gilteritinib option. So what we can say is, as Samantha said, we have a good option for the relapse setting, that is gilteritinib. Gilteritinib will not come in the first line treatment. And in the first line treatment, if we have the choice between quizartinib and midostaurin, it seems that quizartinib is a better option. That maybe in a nutshell is the summary of the studies that we saw within the last couple of slides. Okay, and with that, I would go on to the next abstract, and that is an abstract that looked at the implications of patient-reported outcomes on the prognosis of the disease, of the acute myeloid leukemia. And what happened in this abstract, patients who were elderly but fit for intensive chemotherapy and transplant were treated in an EORTC study. Those patients received either decitabine or intensive chemotherapy, and at the same time with remission parameters, also quality of life parameters were captured. And then in the end, what researchers did is they looked at the implication or the prognostic relevance of those patient-reported outcomes, quality of life parameters on the overall prognosis of the patients. So they looked at physical function, role function, the global health status, and tried to correlate this with the outcomes such as response rates or overall survival. And what you can see here is the main results. And this is a bit difficult to understand even for me. These are the parameters and their influence on the general prognosis of patients. And whenever you see here a p-value of that is lower than 0.05, it means that a change in this quality of life parameter here is prognostic. And that means if patients are more fatigued, have a lower physical function, a lower role function, and a lower general global health status, they have a worse prognosis. And this is irrespective from the chemotherapy they received. And this is also irrespective from the response rates that they achieved with the therapy, which means those results show us that patient-reported outcome, quality of life parameters have a very, very strong prognostic effect, and they have at least a strong, they are at least as prognostic as the response rate to chemotherapy. And that means that capturing patient-reported outcomes, quality of life outcomes in clinical trials and clinical studies is very important, because they also decide on how well patients do in a clinical trial and not only the chemotherapy that patients receive.
Yes, I actually do agree. So I think for patients it's very important that you actually report and be honest when you have this conversation with your physician. And because this, when it is captured, then it's not replacing the medical test and the analysis that the physician would do, but it comes as an additional important information that then physician can use for your treatment.
Mm-hmm. Yeah, I totally agree. Absolutely true. And also for us who do clinical trials, we also need to make sure that we include those patient-reported outcomes in our clinical trials. Okay, with that, I continue to a study for patients who are not fit for intensive chemotherapy, but who will receive a less intensive therapy for the treatment of their newly diagnosed AML. And for those patients, currently the standard is that they receive a combination of a so-called hypomethylating agents, that is most of the time azacitidine and venetoclax. That's a BCL2 inhibitor. Azacitidine is an injection, and venetoclax is a tablet. And the approved dosing for this venetoclax is to give it over 28 days per cycle. And because the combination of venetoclax and azacitidine is not only very efficacious, but it also causes side effects, we have been thinking about whether the 28 days of venetoclax are really necessary for a long time. So many of us thought maybe a lower amount of days venetoclax could be as efficacious as 28 days. So maybe 14 days could be as efficacious, but maybe cause less side effects or adverse events. And in order to find out whether this is true, the colleagues from the US performed a randomized study, the so-called OPTI-AML study. They randomized 169 patients. One half of them received the standard, which is azacitidine plus venetoclax for 28 days, and the other half received venetoclax for 14 days only. And then they looked at the outcomes, and the outcomes are quite surprising. I'd like to draw your attention on the so-called composite CR rate, so then the percentage of patients who has responded, and this is the group of patients who received it for 28 days, and this is the 14-day group. And you see the so-called composite CR rate is slightly higher with 28 days than with 14 days. So it's not, 14 days is not equally effective, but it is slightly less, it's causing slightly less remissions. If we look at overall survival, you are very familiar with these curves now. On the left-hand side is progression-free survival, so patients whose AML has relapsed or is progressing. And on the right-hand side, you see overall survival. And the black curve is patients who received it for 28 days, and the red curve is 14 days of venetoclax. And you see, although these differences are not statistically significant, numerically, there is a slightly higher proportion of patients who survive, or patients do slightly better with the 28 days. And this was significant for a group of patients who have a mutation in NPM1 and IDH2. For those patients, the differences in response rates are very big. So 61% responded after 28 days, and 33% of patients responded after 14 days. And again, very interesting is also the adverse events. If we look at how frequently serious adverse events occur in the two arms, we see again no significant differences, which means the 28 days, they are not more toxic than the 14 days, which is not what we expected. So in general, what we see in a nutshell, and the results of the study is that 28 days does not cause more toxicity than 14 days. And numerically, and in some genetic subgroups, the 28 days may even cause better outcomes than the 14 days. So whenever a patient can tolerate 28 days or more than 14 days, I would rather go, at least for the first 2 cycles, which was the duration for which the study actually investigated those 2 different dosing regimens. At least in the beginning, I would rather go for a more dose-intense treatment as opposed to the 14-day schedule. There is still a lot of uncertainty, or quite some uncertainty, with these data, because we have small subgroups and they were not equally distributed. But based on those data, we can at least say that 14 days is not better and is not causing less toxicity than the 28 days. I don't know how you interpreted the data, or what your thinking is about those results, Samantha.
So it seems to confirm that the 28-day schedule remains the standard, but I would probably think on a patient perspective that it might be harder to complete. And I think actually, if you look at some numbers, you see that only 68% of the patient actually completed the full course of the 28 days. mainly because of the infections. So I would think that maybe prevention of those infections and management during the treatment can have to be a bit better managed, I would say. But the reassuring thing is that the deep response rates are similar between the 14 days and the 28 days. So that's very good for patients.
Exactly, yes. That's a very important point or aspect. If we look at it from a different angle, it also means if patients have serious complications or toxicity, and it seems that continuation of venetoclax beyond 14 days is risky because the patient is already in a bad state or has complications. It also seems that the outcomes are at least not significantly worse with 14 days versus 28 days. So it is not catastrophic to stop treatment after 14 days in a patient who is not well off, because the outcomes do not seem to be so different, really.
Yeah, except for the NPN1 mutated patient or the IGH1 or 2 mutated patient.
Exactly, yes. So those patients should, or in those patients, we should at least try to stick to a dose-intense regimen.
Yes.
Okay, that leads us to the next study, and that is on APL, acute promyelocytic leukemia. That is a rather rare subtype of AML. And this treatment was classically used, this treatment was classically composed of a so-called AIDA regimen, which is intensive chemotherapy, and intensive chemotherapy with all-trans retinoic acid, ATRA. And there was the Apollo study in high-risk APL patients that compared the standard AIDA chemotherapy regimen with an arsenic trioxide-based regimen, and it showed that the arsenic trioxide regimen is associated with better response rates and also better event-free survival, which is, from a medical perspective, I would prefer arsenic trioxide and ATRA versus the old AIDA chemotherapy. But what the researchers did in this study is that they also captured patient-reported outcomes. And this analysis here analyzed these patient-reported outcomes and compared it in the arsenic trioxide ATRA arm with the chemotherapy arm. And the main question is the quality of life at the end of consolidation better or different with ATRA arsenic trioxide than from chemotherapy? And they looked at many different aspects of quality of life and patient-reported outcomes. And what they could show that by the end of consolidation, all these parameters here where it says clinically significant, where it says yes here, all these parameters were significantly better in patients who received arsenic trioxide and ATRA as opposed to chemotherapy. So physical functioning was better, fatigue was better, nausea and vomiting was better, appetite was better, fatigue was better, and also social role and role function was better. To see this as a graphical representation, this is the outcome or the numbers of the quality of life as parameters or scores. And you see here a line, and whenever you see the score on this side here, this indicates that it was better for patients who received ATRA-RTO, so ATRA arsenic trioxide, and whenever you see it on this side, it was better for chemotherapy, and you see it's never on this side. So for almost all patients, these quality of life parameters were better at the end of consolidation if they received arsenic trioxide-based treatment. So my take is based on those data that not only from a medical perspective when it comes to response rates and overall survival or survival in general, but also when it comes to quality of life, arsenic trioxide-based treatment wins or outperforms the conventional chemotherapy. And this is one more argument for me to support this kind of treatment in patients. What's your take, Samantha?
The same as you. I also maybe you did not mention, but it seems that during the initial phase, the quality of life was actually pretty much the same between the two groups, and that the quality of life advantage actually emerged during the consolidation, which then is a good news for patients.
Absolutely. It's a very good point that you mentioned and that I did not mention. Actually, it's true. During induction chemotherapy, it was not really different, but in consolidation. And one reason could be that consolidation with intensive chemotherapy, it means that over, let's say, 4 months or so, patients are mainly in the hospital and receive intensive chemotherapy, which causes mucositis and so on. Whereas with the arsenic-based consolidation therapy, patients are outpatient. They receive infusions on the outpatient department. They are at home. They don't lose their hair and so on. They don't have classical chemotherapy side effects, which is most likely the reason why their quality of life and their patient-reported outcomes are better as well. Okay, so, and I think we finished with a final glimpse of hope again for patients with a relapsed disease, because that is a quite early study, but it shows that maybe in the future also immunotherapy may help patients with acute myeloid leukemia, and in particular in the relapse refractory setting, which is particularly difficult to treat. So what happened in this study? It's an early study for patients with relapse refractory AML or patients with MRD positive AML, so patients who have small remains of AML still detectable. And these patients needed to have CD123, that's an antigen on the surface of the acute leukemia cells, because against CD123 was the immune treatment that was used in the study. So 17 patients were reported. Those patients received lymphodepletion, that is some sort of chemotherapy, and then they received allogeneic CAR T cells against CD123 for induction, and also if they tolerated it for consolidation. And how those allogeneic CAR T cells work is shown here. Imagine you have a normal T cell from an allogeneic donor. So that's a T cell that is not from the patient, but it is from some voluntary donor. Those T cells are modified so that they are not rejected from the body of the patient. So they are modified by removing these parts here, these receptors on the surface, so they are better tolerable. And what is done also in addition is the introduction of a so-called CAR T cell receptor. So that is a molecule that specifically activates this T cell. And this receptor activates the T cell whenever it binds to a linker molecule to CD123, which means whenever this T cell meets an AML cell with CD123 on the surface, and this linker molecule here is present that you can infuse, then the CAR T cells will recognize the AML cells and kind of send out substances or cytokines that destroy the AML cell. The new thing about is that by infusing this linker molecule, you can switch the activity of the T cells on and off. And also the new thing is that you don't need the T cells from the patient itself, but you can take T cells from any donor that are readily available from off the shelf. You don't need to produce it specifically for each patient. This is quite difficult, but also quite sophisticated. And what you can see here is the response rates to this therapy. So each bar here represents one patient. And if you see that the bars are going down, it means reduction of the AML disease. And you see that in particular here in the early phases of the study, when only small amounts of those T cells were used, patients did not respond. Whereas in later stages of the study, when higher doses of the T cells were used, many patients actually responded to treatment. And this treatment response also lasted for a couple of months at least, based on the current results. So that is not a breakthrough yet, and it is not a novel approved treatment, but it shows that this kind of new treatment can actually work in patients with relapsed AML. And this is also raises hopes that with further clinical development, this will make it into routine treatment, although it's still a long way, but there is some hope. Samantha, how did you receive those data?
I'm still very cautious with those very early stage trials. And I mean, this trial is a phase 1 with only 17 patients. So we cannot really have firm conclusions about it, but it seems that the safety signal is pretty encouraging. If I remember correctly, there was no GVHD, so no graft versus host disease, which is one of the major risks for those kind of therapies. And it seems also, if I remember, that the immune side effects happened, but were actually pretty much manageable. So it could be that the safety is encouraging and that potentially could be an option for those pre-heavily treated patients.
Yeah, I totally agree. You're right. With allo CAR T cells, there is a risk of GVHD. It did not occur. And the side effects or the adverse events that happened during treatment, they were there and they were also, let's say, relevant, but they could be managed well. And the hope is that our management gets better also with time and that we may be able to handle those adverse events better in the future. Yeah, and with that, that was my last abstract that I selected. So yes, thanks very much. I don't know, Samantha, whether you would like um, to conclude or whether you'd like to address some more words or messages to the patients. I enjoyed our conversation and I hope patients could take some information out of it that are useful for them.
No, yeah, same for me. It was a pleasure to speak with you today. I think for me, one of the main takeaways is that quality of life starts to be a topic, even though AML remains a challenge to be treated. But with the new options, we see that we are not only talking about survival, but that quality of life also becomes a topic. So this is very good news for patients as well.